Hi, this is Dr. Mahadevan, and we're going to complete our series on advanced airway management with part 5 of our series of lectures. And in the first 4 parts of our lectures on advanced airway management, and specifically endotracheal intubation, we talked about the 6 P's of endotracheal intubation: preparation, pre-oxygenation, position, placement, proof of endotracheal intubation, and then post-intubation management. But today we're going to focus on something called rapid sequence intubation. And rapid sequence intubation, or RSI, adds a couple of elements to the 6 P's. And now it becomes the 8 P's of endotracheal intubation with rapid sequence intubation. We add pretreatment with medications, and then paralysis with induction, also utilizing medications, between pre-oxygenation and positioning to facilitate endotracheal intubation. So let's talk more about rapid sequence intubation. So why do we do this? Why do we add these 2 steps? We know from prior research that we increase our chances of successfully intubating the patient if we use rapid sequence intubation. There's generally less airway trauma because the patient is completely relaxed, so we're not fighting them necessarily to try and insert the endotracheal tube. And importantly, oftentimes when we meet our patients in the emergency department, we may not know when their last meal was. And so if they have a full stomach, we decrease the risk of aspiration when we're utilizing RSI as opposed to endotracheal intubation without the use of these medications and RSI. So step number 3 in RSI is pre-treatment. And so what do we mean by pre-treatment? What are we talking about? But we're actually talking about is the use of certain medications, specifically lidocaine, opiates like fentanyl, and atropine, to try to mitigate the undesirable effects of endotracheal intubation. And what are those undesirable effects? They can include things like an increase in intracranial pressure, an increase in intragastric pressure, an increase in intraocular pressure, other things like bronchospasm. You can get problems like an increase in your catecholamines, so you can get a catecholamine surge. And finally, sometimes, especially in children, you can get bradycardia with endotracheal intubation and the use of certain medications. So the use of these pre-treatment medications is really focused on all of these side effects, undesirable side effects. So let's talk about lidocaine first. Again, it can be used to prevent a rise in intracranial pressure and reduce airway reactivity. And how does it work? It attenuates the adrenergic response to laryngoscopy. So if you're dealing with a patient who might have a head injury and increased intracranial pressure, or an asthmatic patient who might require endotracheal intubation, consider lidocaine as a pre-treatment agent in these patients. Another pre-treatment agent is fentanyl or opiates. And what do? They can blunt the hypertensive response to intubation, or the insertion of that laryngoscope into your pharynx can be very irritating and cause hypertension. So patients where you would consider using fentanyl or an opiate as a pre-treatment agent include increased ICP, and then patients with myocardial infarction or an acute heart attack or aortic dissection, where an increase in catecholamines can lead to a worsened outcome. So these are cases where you would consider using fentanyl or an opiate as a pre-treatment agent. And then finally, atropine is a medication when given prior to intubation, and specifically prior to the use of succinylcholine, can reduce or mitigate the bradycardic response to intubation and succinylcholine. And so generally, we give it to children less than 10 years of age, but I would say it should be given to every child less than 1 year of age, and consider it in adults who are getting a second dose of succinylcholine. So pre-treatment medications are lidocaine, fentanyl, and atropine. And when we talk about the doses of these medications, again, for lidocaine, it's going to be 1.5 milligrams per kilogram, whether you're an adult or a child. When we're talking about opioids, and specifically fentanyl, we're going to use 3 to 6 micrograms per kilogram and a slightly smaller dose in children. And then the dosing of atropine is 2 milligrams in adults, or in children, 0.02 milligrams per kilo, with a minimum dose in all kids of 0.1 milligrams. So we just talked about pretreatment. The next step in rapid sequence intubation is paralysis with induction. So let's talk about that. When we're talking about induction, what is an induction agent? It's an agent that rapidly induces unconsciousness, and it also enhances a patient's relaxation when given in conjunction with a paralytic agent. So remember, a paralytic agent is going to paralyze the patient but not knock them unconscious. And there's nothing worse than being paralyzed but aware of what's going on, that somebody's inserting a tube into your throat and into your trachea. So we should always give an induction agent when we are giving a paralytic agent. What is the ideal induction agent? What are its properties? It's going to work fast. It's going to be short-acting. It's not going to affect a patient's blood pressure. And it might have some beneficial effects, such as decreasing intracranial pressure, dilating their respiratory tree, causing a little bronchodilation, or maybe even having an anticonvulsant effect. So we're going to think about these beneficial side effects when we're trying to choose the ideal agent for rapid sequence intubation. The most commonly used induction agent currently is etomidate, and the dosing is going to be 0.3 milligrams per kilogram. The onset of action, generally 15 to 45 seconds, and it's going to last about roughly 10 minutes on general. Some beneficial side effects are that it decreases the ICP, and another beneficial side effect is it doesn't drop your blood pressure as much as the other agents. So we like it especially for use in trauma victims. Another induction agent that's used for a specific kind of disease process is ketamine. And we like to use ketamine as an induction agent in patients with reactive airway disease. The dose is going to be 1 to 2 milligrams per kilogram. It takes about 1 minute to take action. It's going to last anywhere from 10 to 20 minutes. And again, the reason that we like it is it has these bronchodilatory effects. So it may have a benefit in these patients who are really tight and might benefit from some additional bronchodilation. After giving the induction agent, or in association with the induction agent, we want to give a paralytic agent. And why do we give a paralytic agent? Because we want to induce complete muscle relaxation to facilitate the act of endotracheal intubation. What does the ideal paralytic agent look like? Again, it's going to work very rapidly. It's going to have a short duration of action and hopefully have very few side effects. Unfortunately, there is no ideal paralytic agent which matches all of these characteristics. So the two groups of agents that we use are depolarizing agents, most commonly something called succinylcholine, and then non-depolarizing agents, most commonly rocuronium. And succinylcholine, the dose is going to be generally 1.5 milligrams per kilogram in adults, and in children 2 milligrams per kilogram. And in children and adults, the dose of rocuronium, a non-depolarizing agent, is generally going to be 1 milligram per kilogram. Why do I keep mentioning succinylcholine? Why do we use succinylcholine? Even though it has a number of side effects, which I'm going to discuss shortly, the reason that it's used most commonly is it has a great profile as a paralytic agent. It works very rapidly, it's generally short-acting, and it creates the shortest time to optimal intubating conditions. Contrast that with an agent like rocuronium, which can last anywhere up to 60 minutes. So once you've given it, you can't take it away generally. And so you're going to have to intubate the patient because they're going to be paralyzed anywhere from 30 to 60 minutes. Succinylcholine, on the other hand, lasts a shorter period of time. Now, what are the adverse effects associated with succinylcholine? You're going to see things like muscle fasciculations, generally after the administration of succinylcholine. As I mentioned, bradycardia can occur especially in really young kids. It can induce hyperkalemia, which in a at-risk patient can lead to dysrhythmias and cardiac arrest. In some patients, you can induce prolonged neuromuscular blockade. Again, in some patients, a complication is something called malignant hyperthermia. And finally, it can cause masseter muscle spasm or trismus, which can make it very difficult to intubate the patient in some patients. So these are the complications or adverse effects of succinylcholine that you need to be aware of. Succinylcholine also has some very specific contraindications. These are reasons not to give the medication. Fortunately, they're fairly rare, but you need to keep them in mind. In any person who is greater than 5 days after acute burns, you're not going to want to give succinylcholine, so don't give it in these patients. In any patient who's had a spinal cord injury or stroke and they're greater than or equal to 5 days out, you're going to want to avoid succinylcholine. In any patient that has neuromuscular disease like ALS or multiple sclerosis, avoid succinylcholine. A recent crush injury, more than 5 days, avoid succinylcholine. A recent intra-abdominal infection and you're greater than 5 days, avoid succinylcholine. Anybody with a history of myopathies or a history of malignant hyperthermia, absolutely avoid succinylcholine. And then again, in anyone with renal failure or missed dialysis, you're going to want to use rocuronium instead of succinylcholine. The reason that succinylcholine is contraindicated in all of these patients is that in this particular group of patients, administration of succinylcholine can lead to an exaggerated rise in your potassium, anywhere from 5 to 10 milliequivalents per liter. And what can happen when your potassium suddenly rises 5 to 10 milliequivalents per liter? That can lead to cardiac dysrhythmias and cardiac arrest. And so we obviously want to avoid that in these patients. So we're going to want to avoid using succinylcholine in this group of patients. So to summarize, if we're not performing rapid sequence intubation, there are 6 Ps to endotracheal intubation: preparation, preoxygenation, positioning, placement, proof, and finally, post-intubation management. When we're using rapid sequence intubation, we're going to insert 2 more Ps: pretreatment. Remember, pretreatment with either lidocaine, atropine, or an opiate like fentanyl, depending on the patient's condition. And then we're going to paralyze the patient with either rocuronium or more commonly succinylcholine. But whenever we give a paralytic, we always want to give an induction agent like etomidate or ketamine or benzodiazepine like midazolam to knock the patient out, to induce unconsciousness, as well as help with some of their pre-existing conditions such as increased intracranial pressure or reactive airway disease. So we're going to add these 2 steps, pretreatment and paralysis with induction, when we're performing endotracheal intubation with rapid sequence intubation. Again, the 8 Ps. Thank you very much.